Hello everyone. In this video, we will talk about antifolate and fluoroquinolone. The fluoroquinolones are not antifolate drugs. While antifolate drugs are also called anti-metabolite drugs, you can simply write AM, anti-metabolite drugs, because they are structurally competitive inhibitor of folic acid synthesis or folate inhibitors simply called. So the antifolate are further include the streptomycin and sorry streptomycin is not antifolate drug. Streptomycin is actually a aminoglycoside. Spectinomycin is also a aminoglycoside. The antifolate includes sulfonamides. The sulfonamides are actually antifolate drugs, and the other is trimethoprim. Okay, trimethoprim, sulfonamide, trimethoprim, and the trimethoprim sulfamethoxazole. These are antifolate drugs, also called anti-metabolite drugs. What they drugs do, they sequentially block, they inhibit sequential steps in the bacterial metabolism of folate. In the synthesis of folate, the first step is para-aminobenzoic acid is converted into dihydrofolic acid via complete synthetic reaction catalyzed by enzyme dihydropteroid synthase. This enzyme is blocked by sulfonamide, which actually compete with para-aminobenzoic acid. Okay, so they are sulfonamide and trimethoprim, which are also called anti-metabolite drugs. Starting from sulfonamide, the sulfonamides are actually the weakly acidic compound. Okay, weakly acidic compound, while trimethoprim is not a weakly acid, it is a weak base. Okay, we have to study two important drugs, trimethoprim and sulfamethoxazole. The sulfamethoxazole is weakly acidic, while trimethoprim is weakly, okay, trimethoprim is weakly base, while sulfonamide is weakly acidic compound. Sulfonamide have common nucleus resembling para-aminobenzoic acid. So they compete with para-aminobenzoic acid for enzyme dihydropteroid synthase, and they competitively block dihydropteroid synthase. There are many individual members of sulfonamide. Okay, they differ on their pharmacokinetic properties and their clinical uses. Some act as short acting and oral use, while some are long acting and some have topical use. Okay, so they differ on their pharmacokinetic properties and clinical use. What are their pharmacokinetic properties? These include modest tissue penetration, this means smallest tissue penetration, hepatic metabolism, and excretion of acetylated metabolites in the urine. They are weakly acidic compound and their solubility is decreased in the acidic urine. So if the urine is acidic in nature, then there will be precipitation of sulfonamides. Okay, sulfonamides. So that because of their solubility limitation, the combination of three sulfonamide like triple sulfa will reduce the chances of precipitation. The sulfonamide are divided into short acting, intermediate, and long acting on the basis of their duration of action. The short acting include sulfoxazole, sulfastamide, sulfadiazine, while intermediate include sulfamethoxazole. And this drug is used in combination with trimethoprim called trimethoprim sulfamethoxazole, while long acting include sulfadoxine, sulfasalazine, while topically applied drugs include mefenadine and silver sulfadiazine. They are topically applied. They are used for burn infections. So we have talked about their pharmacokinetic properties on the basis of their duration of action. Let's talk about their clinical uses. The sulfonamide overall, they are active against both gram negative and gram positive. So we write gram positive and gram negative. They are also active against chlamydia and nocardia, CN, Cartoon Network, chlamydia and nocardia. They are also against chlamydia, nocardia, gram negative, gram positive organism. If we talk about selective clinical uses of individual drugs, then we should note that sulfaxazole, the first drug, sulfoxazole or sulfoxazole, this drug along with triple sulfa is used for urinary tract infection UTI, okay, while sulfacetamide is used for skin infections, okay, sorry, ocular infection, while mephenide or sulfur sulfuridiazine they are used for burn infection. The sulfasalazine is used for ulcerative colitis, rheumatoid arthritis, sulfasalazine, while burn infection is treated by mephenide and silver sulfadiazine. They are used for burn infection. The toxoplasmosis is treated by oral sulfadiazine and pyrimethamine. Pyrimethamine is again a dihydrofolate reductase inhibitor, just like trimethoprim is. Next is trimethoprim. Trimethoprim is dihydrofolate reductase inhibitor. Dihydrofolate reductase inhibitor. Okay, and this drug is weakly based, so it is trapped in the acidic environment. And in male, it reaches in high concentration in prostate, and in female, it reaches in high concentration in vagina. The half-life is similar to that of sulfamethoxazole, so that these drugs are combined used. Now, let's talk about trimethoprim sulfamethoxazole, which is also called cotrimoxazole. Cotrimoxazole. What are their clinical uses? This drug is effective orally. It is used in urinary tract infection (UTI) and also used for Haemophilus influenza and Moraxilla catarrhalis, which causes infection of respiratory, ear, and sinuses. So, Haemophilus influenza and Moraxilla catarrhalis. Also, in immunocompromised individual due to HIV or immunotherapy, immunosuppressive therapy, they are also used for Aeromonas hydrophila, and they are drug of choice for pneumocystis pneumoniae, which is also a opportunistic infection common in AIDS patient. This drug is also used for nocardia, typhoid, shigella. The mnemonic is STN. Okay, stent, STN. So, what are the clinical uses of this drug? This drug has many clinical uses, starting from the last STN. Shigella, typhoid fever, nocardiasis, also used for cholera, staphylococcus, specifically MRSA, Listeria monocytogenes, Aeromonas hydrophila, Pneumocystis jirovecii, and also used for UTI and Haemophilus influenza moraxilla catarrhalis. So it has many important clinical use, but you have to remember only few one, which I am telling you. A urinary tract infection, okay, simple urinary tract infection. This drug is used also for respiratory air sinus infection caused by Haemophilus influenza, Moraxilla catarrhalis, Pneumocystis jirovecii pneumonia, toxoplasmosis, and nocardiosis. These are important, while rest are less important. This was all about trimethoprim sulfamethoxazole. Next, talk about fluoroquinolones. The fluoroquinolones are DNA gyrase inhibitor or DNA topoisomerase 4 inhibitor, which is also called DNA gyrase. Okay, DNA gyrase. What their drugs do? They they block the DNA topoisomerase type 2. Okay, type 2 in gram negative and type 4 in gram positive. So it blocks gram 4, sorry, topoisomerase 4 in gram positive and 2 in gram negative. So by inhibiting the DNA topoisomerase, DNA gyrase, they block the relaxation of supercoils, and the relaxation of supercoils is normally catalyzed by gyrase. DNA gyrase. If there is no relaxation of supercoils, then there will be no transcription, no replication of DNA molecule. So these drugs are active during the active cell cycle or cell division of bacteria. So they are usually bactericidal. Bactericidal, like aminoglycoside. These drugs also inhibit post-antibiotic phenomena. Post-antibiotic phenomena. What is post-antibiotic phenomena? Post-antibiotic phenomena means that if the minimal inhibitory concentration, if the drug concentration falls below minimal inhibitory concentration, these drugs are even able to inhibit the bacterial growth. So they have post-antibiotic phenomena. What are their resistance mechanism? For sulfonamide, there can be resistance mechanism due to plasmid mediated or chromosomal mediated. Okay, mainly this may be plasmid mediated. What are the mechanisms? The first mechanism is decreased intracellular accumulation of drug. Number two is first is decreased accumulation of drug. Number two is increased production of para-amino benzoic acid by bacteria. So to reverse the competitive inhibition while decreasing sensitivity of dihydroteroid synthase to sulfonamide, while trimethoprim resistance is acquired by production of dihydrofolate reductase, which has reduced affinity for the drug. For fluoroquinolones, there may be resistance to many mechanisms, but we will talk about first the classification of fluoroquinolones, which inhibit the DNA guidase, DNA topoisomerase, 2 in gram negative, 4 in gram positive. What are the classification? They are divided into two groups, narrow spectrum and wider spectrum. The narrow spectrum include norfloxacin, first generation, okay, and the wider spectrum include second generation ciprofloxacin, ofloxacin, while the third generation include gemifloxacin, moxifloxacin, levofloxacin. Okay, the first generation norfloxacin is derived from nalidixic acid and it has activity against urinary tract infection pathogen, while second generation fluoroquinolone include ciprofloxacin, ofloxacin. These have activity against both gram negative and gram positive. Okay, gram negative organism, gram positive cocci, also active for mycobacterium and atypical pneumonia caused by mycoplasma and chlamydia pneumonia. The third generation include the respiratory group gemifloxacin, moxifloxacin, and the levofloxacin. They are specifically active for gram positive cocci, including Staphylococcus, specifically methicillin resistant Staphylococcus, Streptococcus pneumoniae, and Enterococci. These are all against all gram positive cocci. Okay, the third generation are also called respiratory because also they have broader spectrum than other first and second generation against anaerobes. So they are also used against anaerobes. Third generation fluoroquinolones. Talking about resistance mechanism, so the second generation fluoroquinoline, ciprofloxacin, ofloxacin resistance is important in Campylobacter jejuni and gonococci, also in MRSA, methicillin resistant Staphylococcus aureus, Pseudomonas aeruginosa, and Serratia species. The mechanism is same, that is decreased intracellular accumulation of drug via efflux pump, and also in gram-negative bacteria there is changes in porine structure. Porine structure. The efflux mechanism is important for the resistance in Mycobacterium tuberculosis, Staphylococcus aureus, and Streptococcus pneumoniae. Also, the changes in the sensitivity of target enzyme are also established for resistance mechanism, and the mutation in the quinolone resistant determinant region of DNA guidase A gene. This gene encode DNA guidase. So there is also a mechanism for the resistance in many other microorganisms. Okay, what are their clinical uses of fluoroquinolones? Fluoroquinolones are effective in the treatment of infection of urogenital and GIT caused by gram-negative organism, including gram-negative cocci, gonococci, gram-negative rods, E. coli, Klebsiella pneumoniae, Clostridium jejuni, Pseudomonas aeruginosa, Salmonella, Shigella. Okay, they are also used for respiratory tract, skin, and soft tissue infection. The ciprofloxacin, ofloxacin, second generation, they are important as alternative to ceftriaxone and cefixime in gonorrhea. The first is gonorrhea as alternative drug to ceftriaxone and cefixime. Ceftriaxone, cefixime are cephalosporin, specifically third generation cephalosporin. Okay. Ofloxacin is also active against Chlamydia trachomatis. Levofloxacin has some activity against organism, just like pneumonia acquired, community acquired pneumonia, including Chlamydia, Mycoplasma, Legionella species, while gemifloxacin and moxifloxacin are having the widest spectrum of activity, which include gram-positive, gram-negative organism, atypical pneumonia agent caused by Mycoplasma and Chlamydia, and some anaerobic bacteria. Also, fluoroquinolone are active against meningococcal carrier state. They are also used in the treatment of tuberculosis and the prophylaxis of neutropenic patient. This was all about fluoroquinolone. Hope you have liked this video. Please subscribe our channel for more updates. Thanks for watching this video.